Coutinho from Brazil, and Conrado is associate professor in São Paulo University in Brazil, and he's going to give a talk on the abnormalities of the placenta and umbilical cord. So thank you so much. I look forward to hearing you.
Thank you very much for having me here. My name is Conrado Coutinho, and I'm going to present to you now some of the most prevalent and main abnormalities of the placenta and the umbilical cord. So let's start with a clinical case. We have a patient at her first pregnancy at the beginning of the third trimester of pregnancy with a second episode of vaginal bleeding and a little bit of abdominal pain in the lower abdomen. Not really important. But we have to think about differential diagnosis for these second trimester bleedings. And if we have patients with milder pains, we should think about vasa previa from the rupture of these unprotected vessels close to the cervix, or low-lying placentas or placenta previa. On the other hand, if we have patients with a lot of pain, uterine contractions, we should think about the possibility of abruptio placenta and uterine rupture before the complete rupture of the myometrium. So this patient came to our hospital. I had the opportunity to study with a portable machine, and what I saw in this transabdominal sagittal view is that the placenta was covering the internal os of the cervix. So it was a placenta previa, but more than that, we had an abnormal structure here on the fetal part of the placenta, close to the lower edge of this placenta. Hypoechogenic mass, it seemed to me like an old hematoma. Patient was well, fetus was fine, normal fluid, fetal was moving. We admitted the patient, introduced corticosteroids, and the patient went well for the next few days. But 5 days after this second bleeding, she had another episode of bleeding, but with uterine contractions, clinical signs of abruptio, and in fact, she had a new abruptio placenta, as we can see here, this clot. And that image was really a chronic hematoma on the fetal part of the placenta. But more than that, the patient also had velamentous cord insertion, as you can see here. So 3 conditions in just one patient, and this shows why it is important to have an ultrasound machine in the maternity suite to make this kind of differential diagnosis. And not only for this patient, but for every patient, because if a patient arrives at the maternity bleeding, we must know if the placenta is low-lying or previa before doing a vaginal digital examination. Otherwise, we can make the abruptio happen if we don't know this information before doing this kind of examination. Well, and it's for sure, we have talked today a lot about fetal conditions, and it's impossible to compare the empathy of the fetus to the empathy of the placenta and the umbilical cord. But my mission here is to tell you that we should have a good look every time we do an obstetric ultrasound to the placenta and umbilical cord. We have to mind the placenta because these conditions might happen, they are there. The placenta might be low-lying or previa, and the further we see this condition on ultrasound, the more probable it will be that the placenta is going to be previa at delivery. In special to patients with previous cesarean sections, where these placentas might have some more difficulties to move up during pregnancy. How do we do it? We can start with a transabdominal view, and here you can see 2 transabdominal sagittal views of the placenta and cervical canal. And the most important thing is to observe this relationship between the internal os and the lower edge of the placenta. And if this distance is more than 15 to 20 millimeters, this varies according to international guidelines. ISWOG usually recommends 15 millimeters as this cutoff. So if this measurement is higher than 15 to 20 millimeters, we call this normal placentation or high placenta. If the placenta completely covers the internal os of the cervical canal, we are going to call it placenta previa. And if in the cases where the placenta, the lower edge of the placenta is really close, below 15 to 20 millimeters to the internal os, we call these low-lying placentas. And in many conditions, it will be better to do a transvaginal examination to perform this assessment here as shown in these pictures. Why it is important to know this? Because the location of the placenta might be related to other pathologies, but mainly to what will be the mode of delivery. So we recommend universal screening for low-lying placenta previa at the second trimester anatomy scan. And if the placenta is high, nothing must be done with regards to this condition. But if the placenta is low or previa, we are going to have to see this patient again in the beginning of the second trimester, at the end of the second trimester. And if there is a persistent placenta previa, this patient might have the need to have an elective C-section between 36 and almost 38 weeks of pregnancy. On the other hand, if the placenta is low-lying, it will depend on that measurement that I show you in the previous slide. If now this patient has a distance from the lower edge of the placenta to the internal os below 10 millimeters, the probability of having vaginal delivery is less than 50%, so a C-section is recommended. On the contrary, if this distance is between 11 to 20 millimeters, there's high probability of having vaginal delivery, so we can expect for this kind of the start of the contractions for the vaginal delivery. For sure, if there is any need for abbreviation of this resolution because of bleeding or maternal or fetal emergencies, an emergency C-section might need to be done. Well, so let's see another condition related to low placentation. Let's imagine tomorrow morning, we're going to see a patient, first ultrasound during pregnancy, and usually we pay attention to the number of fetuses, to the location of the gestational sac. We measure a CRL. We say that this pregnancy is 7 weeks and 2 days. Most times we do not observe where the placenta is. We can see this patient again during the second trimester anatomical scan. We do brilliant images, show the sex, the baby face, patient is happy. But when we are going to write our report, we arrive at the placental location region here of the report, and we ask ourselves, where was the placenta? Who never done it? We have lots of patients to see. And at this moment, we have to be more resilient than Jesus Christ in the desert. And we have to avoid looking back at the images in the systems instead of bringing the patient back to the room, because otherwise we can have a glimpse of where the placenta is. We will write our report, the placenta might be anterior or high, but 10 weeks later, what someone can observe when they are going to deliver that patient is a condition like this, a placenta accrete spectrum, PAS disorder. And this might be put the patient at risk of morbidity and mortality during the procedure. So once again, I urge you to pay attention to the placenta during every ultrasound examination, because if we see this condition, we have to send this patient for confirmation or exclusion of this diagnosis by a specialist referral center. These patients need to be delivered by a multidisciplinary team by elective C-section between 34 and 36 weeks to have good conditions. And many add-ons might need to be used during surgery for better outcomes. And so once again, we have to screen not only for placenta previa, but I urge you that we need to screen for PAS at every pregnancy. We can do it from the first trimester, from the early pregnancy. There are signs of cesarean scar pregnancy that might indicate the risk for PAS, but at least we should see these patients at the second and third trimester at every opportunity. And what we should look for: if the placenta is low and if it's persistently low at the third trimester, the reason for this webinar. And if the placenta is low, we have to know if the patient has previous uterine surgeries, because if she has previous uterine surgeries, and a persistent low-lying placenta at the third trimester, this patient has to be referred for a specialized center to confirm or exclude this diagnosis. With this strategy, 96% of acritas are going to be diagnosed before delivery, what can save lives. At the specialized center, we are going to look for lots of these signs of placenta acrita spectrum, in special these in red that are the loss of clear zone, bladder wall interruption, placental lacunae, and some cervical involvement that are related to worse prognosis. So let's see an exception, because the exceptions might occur. This patient is another patient with a completely normal second trimester anatomy scan. Look, no signs of placenta. We were looking at the cervical length for prediction of preterm birth. No signs of placenta, maybe a little bit of hypervascularity on the upper lip of this cervix. But thankfully, someone paid attention to the placenta during a 28-29-week scan and sent this patient to our specialized PAS team. And we could see that there was a lot of remodeling by this moment of the cervix. As I told you, it is an indicator of bad prognosis. And as you can see here, all signs of placenta acrita spectrum, but interestingly, in a higher placenta, not close to the cervix, because this patient had a previous corporal C-section at 23.5 weeks in the last pregnancy. That's why we can see all this bulging, no myometrium, loss of clear zone, all this hypervascularity within the placenta and within the cervix. And it's really important that we see this, because multidisciplinary team might need to know where is this defect, what they are going to need to do in terms of skin incision, use of embolization, many things that might need to be planned beforehand. And this was what we saw during the C-section, a really bad case of acrita. And this is the gross anatomy of the specimen after hysterectomy. We don't need to do hysterectomy in all cases. There are many cases that we can do conservative management, but imagine if we haven't seen this before delivery. Other kinds of the abnormal implantation might occur. We have always to see where the placenta is, not only when it's anterior low, but let's see, for this patient that had a previous cornual pregnancy, she had a defect in the myometrium here, and in the next pregnancy, she had eccentric implantation close to that region. And as you can see here, there was an abnormal implantation. This is also a cesarean scar pregnancy, but not on the scar region, the C-section region, but on this previous uterine surgery. So if the patient has a previous uterine surgery, we might be aware of that and look for signs of abnormal placentation. This patient had a really uncomplicated miscarriage, a spontaneous miscarriage, but if we haven't seen this, it's another patient and that had a vaginal delivery, and we were not able to remove the placenta without doing a laparotomy. So we need to know it before delivery. And let's finish this presentation talking a little bit about some of the abnormalities of the umbilical cord. We also have to be very mindful of the umbilical cord at every obstetrical examination. The better situation is to see a central insertion. If we have marginal insertions, we might have some additional problems for these patients. Another thing that we might need to observe is the number of umbilical arteries, because single umbilical artery is really prevalent, 1% of singleton pregnancies and 3% of twins, and might be associated with other associated congenital malformations, fetal growth restriction, and intrauterine fetal demise. So this might be better investigated in fetal medicine unit centers if detected. If we have marginal insertion, what we might have as well is a velamentous cord insertion, where we have these vessels unprotected by Wharton jelly. And if they are close to the cervix, we might have problems at the delivery, such as the rupture of vasa previa It's rare, 1 in 1,200 pregnancies, but it might lead to hypoxia and intrapartum death. We don't have lots of evidence-based conclusions and recommendations about Vasoprevir, but we have some recommendations from specialists. We should not adhere to this limit of 2 centimeters from the internal os. At every transvaginal ultrasound examination I turn on the Doppler and I look for Vasoprevir until where I can see with my transvaginal examination. I usually recommend this universal screening for Vasoprevir. Every patient during the anatomy scan, I look for cervical length, I look for Vasoprevir, and I look for isthmus seals and low placental implantation. And the importance of looking at these and to know that the patient has Vasoprevir is to avoid the start of spontaneous contractions, the rupture of the membranes that might initiate fetal bleeding, and we usually recommend cesarean delivery between 35 and 37 weeks of pregnancy. And it's usually more common for patients with reproductive assistance and for patients with low-lying placenta, placenta previa, and bilobate placentas, as you can see here. So we have to also mind the umbilical cord. ISWOG has developed lots of guidelines, first trimester, second and third trimester guidelines, and in all guidelines, minimum requirements are to look for the placenta, the aspect of the placenta in the first trimester. Location is not that needed in relation to the internal cervical os, but yes, if the patient has a previous C-section, we have to see if the implantation is related to the previous niche or C-section scar. On the second trimester scan, no doubt we have to look for placental position, appearance, and umbilical cord insertion, entry vessel, and the presence of the number of vessels of the cord. This is recommended as well. And in the third trimester, every time we're going to see an obstetrical examination, we should assess the location of the placenta and the location in relation to previous uterine surgeries. If the patient has low-lying or previa and previous uterine surgeries, this is a positive screening for PAS. Send the patient for specialists to exclude or confirm this diagnosis. So this brings me to the end of my presentation. I talked to you about most prevalent abnormalities of the placenta and umbilical cord, in special low-lying placenta, placenta previa, accreta, Vasoprevia. Of course, there are many other conditions such as placental tumors, knots, cord entanglements in monochorionic twins, defects of the myometrium. We have to be mindful of the placenta and umbilical cord, underlying myometrium in cases of previous uterine surgeries at every gestation, every opportunity. We don't have time to talk about these other conditions, but I am available to discuss that in our discussion panel. Thank you very much for having me here, and have a nice day.
Thanks very much, Conrado, for a fantastic talk. And I loved your moment where you described sitting down and doing your report and you said, oh my God, where's the placenta? And that's something we all do in sort of daily practice. I shouldn't say daily practice, but it's one of those common scenarios where you say you spend so much time looking at a beautiful looking baby and describing all the anatomy, but damn it, you forgot to look at the placenta. And so important for so many reasons, which you've beautifully highlighted in your talk.